Okay, dear students, you are welcome to this session. By name Kiden Robina, and I will still be taking you through antenatal care. So, by the end of this session, you should be able to describe the principles and components of antenatal care, explain the importance of antenatal care, assess fetal well-being during antenatal care. So, what is antenatal care? Antenatal care, in other words, we can abbreviate it as ANC, and is a health care that is provided to pregnant women to optimize their health and the health of their their fetus without throughout pregnancy. So throughout that process of pregnancy, from the time of conception until they deliver, they are supposed to be under strict health care that keeps observing and monitoring how the growth of the fetus is and how it is affecting the mother and what can be done to help. So, what are the benefits of antenatal care? So, the benefits of antenatal care is to one, enable early detection and management of complications in case of any changes that happen, whether with the mother or with the fetus. We can detect on time before things go bad. Then promote healthy behaviors. Then prepares mothers for better and for birth and parenthood. More so the first time mothers, the prime gravidas, prepare them on how to handle the the babies, and what and how to feed their baby and what to feed the baby on. Then fosters emotional well-being. In other words, the mother is prepared for what may come on her way or what is likely to happen to her in the future. So, first prenatal visit. In the first prenatal visit, there is the information that is delivered on the mother stresses on stress and exposure to abuse and the violence. It covers that we find out from the mother whether there is any stresses that the mother is going through, or generally is she being abused? Is there any kind of violence that is happening to the mother? Then medication and the drug use, any medication that the mother is on, because it's very, very important. In case the mother is on any medication, we need to know which one. Is it a type that will affect the baby, or is a type that is safe for the baby? Then we also need to trace and find out about any support that the mother has. Then, in addition to that, we also offer her our support, and we explain to her the support that she may need, and whom she can contact in case she is faced with some challenge. Then establishment of trusting relationship, that creation of rapport. We explain ourselves to the mother, and we make her understand that we shall be there at any time to help her in case of any problem. So that trust should be created. Then focus on education for overall wellness. So in this case, we basically educate the client about changes that will affect her life so that she is aware of them, and she knows how to overcome them in case they have occurred. Then detect and prevent potential problems that may occur in pregnancy. Comprehensive health history, physical examination, and laboratory tests. These are all carried out during the first prenatal visit. So let us look at comprehensive health history. So what is the reason of taking a comprehensive health history. One is suspicion of pregnancy. When we suspect pregnancy, we are not sure whether the mother is pregnant or not. We need to check thorough history to find out whether to confirm the pregnancy or to rule out the pregnancy. Like, for instance, you suspect someone is pregnant, but if you interrogate her, she only had intercourse maybe like 6 months ago, and you expect that if it was 6 months ago, then the abdomen should be so enlarged, but it is flat. Then basically you just cancel it out. There's no need to go further. So that is the reason why we dig so much into the history to find out and confirm whether she may be pregnant or not. Then date of last menstrual period. When taking the history also, we want to find out the date of her last menstrual period. And here we are not looking at the day when she last saw the menstrual periods. We are looking at the day that last menstrual period started on. If she started on the 4th and ended on the 8th, we don't write the 8th, we write the 4th. Why? Because that is the date when she started. Then signs and symptoms of pregnancy. We also ask the mother. We take the comprehensive health history to find out of such signs. Then urine or blood test for HCG. We also establish that we take those samples and they check. So under this comprehensive health history, one, we have past medical history. So in the past medical history, we ask the mother whether she has ever been operated. Has she ever gone through any operation, any surgery? Has it been done on her? Then personal history of what might have happened to her. We also find out about that. Then woman's reproductive history. We find out about her menstrual, obstetric and gynecological history. So menstrual, I have already stated. We find out the last her menstrual period, the first day of the last menstrual period. Then obstetric, has she ever been pregnant before? Which number of pregnancies? This one, those earlier pregnancies, did she have any miscarriage? And things like that. Gynecological history, has she ever had any infections that affected the reproductive system that was treated? Like, for instance, maybe she had an abortion and she needed to be done cleaning. So all those that we ask about them. Then the nurse needs to establish trusting relationship and together develop plan of care. Ultimate goal for first prenatal visit is to collect baseline data to detect risky factor. Now, the baseline of uh, all happenings that will happen during the pregnancy is established at this level, which is the first prenatal visit. So it involves also investigations like taking the weight, taking temperature and blood pressure. Then we record them. So in future, as the pregnancy continues developing, we keep monitoring what we are now getting when we do the investigation. Does it really deviate so much from what was already put down as the baseline data, or there's no much deviation? So this is what we are meaning here. So let us look at menstrual history, and then let's look at the menstrual cycle. So when we are asking the mother about her menstrual history, we ask the mother basically about the age of menarche. At what age did she start menstruating? This is very important because antenatal care involves counseling, and we need to all understand that mothers who get their menarche at earlier age, those who start seeing their periods at earlier age, always uh, take long to reach their menopause. So they have a long duration of reproductivity. So that also can be told to the mother. Then for those who delay, like there are some mothers who even reach up to 18 years, they start their menarche at 18. They see their first period at 18 years. Those ones, their period of reproduction is reduced, and normally they go for early menopause. So if you get a mother like that who has seen her menarche late, it's very important to advise her that as you plan your reproduction, please make sure that you understand that you are likely to go into early menopause. That because based on research, that is what the data says. Then you also ask the mother what are the days in the cycle. There are some mothers who have 28 days, others 29, others 30, 32. So it varies. So it's very, very important to establish this. Then flow characteristics. Does the blood flow in large quantities? Does it flow with the clots? Is it a plain blood? Uh, does is the quantity much, or it is light, is less? So all those are established. Kind of discomforts when she goes into her periods. Does she have back pain? Does she have other signs and symptoms, or things like headache? Do such things affect her? Then is she using any contraception? So all this. So this we take them more so about the flow characteristics, whether the blood is coming much or not. Then the kind of discomfort is because some of the gynecological diseases may present with certain characteristics in terms of flow, so they can be established here. Like if the mother says that when I go into my menses I go for 2 weeks, or someone says I go for only half a day, then there is a problem. She may need to see a doctor because the normal period is between 3 days to 7 days. That is what is considered normal. Then does it come with clothes? Does she feel a lot of discomfort? So all these have to be established to rule out any complications. Then date of lasting menstrual period. So we established this, like I said before, that we ask for the first day of her lasting normal menstrual period. So this is used for calculating the expected date of birth of the baby. Then calculation of estimated or expected date of birth or delivery. So can be abbreviated as EDB, standing for expected date of birth, or EDD, standing for expected date of delivery. So here mainly we use the Nagel rule. And the Nagel rule, like I mentioned in the previous recording, that this involves the addition of the date and the year. So the month will be adjusted accordingly. Now, for example, someone who had her last normal menstrual periods on 21st of November 2017. Now, what will happen when we use Nagel's method? We subtract 3 months from the month. So when we subtract 3 months from the month, from November, if you subtract 3 months, we shall remain with um, we shall remain with 8. That will mean August. From 11, when we subtract 3, we shall remain with 8. Then then we go to the date. On the date we have to add 7. So it will be 21 plus 7, which gives you 28. Then from there we go to the year. The year now we add 1. So one thing we need to be careful about is it depends on the month for us to add 1 on the year. If the mother was pregnant saw her last menstrual period between January, February, March, we are not going to add anything on the year. Because when you count, the 9 months will still end within that year. So in that case, we don't add anything on the year. But if the mother sees her periods from um, from late March up to December, definitely there we need to add 1 on the year. So gestational or birth calculator or will, we shall see it as we continue. Then ultrasound is the best method of dating a pregnancy. So much as we do this calculation, but ultrasound is the best way of estimating the months of the pregnancy, especially if women have irregular periods. So you may not be able to establish. So right here we have image of the whale. This is the whale, which is there. Then let us look at obstetric history. In obstetric history, we ask about the gravida. The gravida states a period, a pregnant, stands for a pregnant woman, or a period. Gravidity is a period of pregnancy. So gravida states a pregnant woman. So let us talk about, you'll be coming about across words like gravida 1 or primigravida. So primigravida is a person who is pregnant for the first time. Then gravida 2 or second gravida. This is a person who is pregnant for the second time, and many others. Now, all pregnancies are counted even if they are miscarried. For instance, if the person is having pregnancy for the 4th time, she has 2 children, and the other child was miscarried. That means that the pregnancy came out before it could grow up to term. When we are talking about her pregnancies, we don't ignore. We cannot say that she's now gravida 3. Why? Because she miscarried the other one. No. We say gravida 4. Gravida 4 para 2 plus 1. Why? Because the other one was miscarried, but the 2 are delivered. So let us look at para. Para stands for a woman who has produced 1 or more viable offspring, carrying a pregnancy 20 weeks or more. Anything that comes out before 20 weeks is considered an abortion. So when we talk about parity, we are referring to pregnancy that has reached up to more than 20 weeks. Whichever pregnancy that comes out before 20 weeks is referred to as an abortion. Let us look at primipara. Primipara, here this one refers to one birth after a pregnancy of at least 20 weeks. She delivers for the first time. Then multipara, this is a person who has delivered 2 or more pregnancies, and these pregnancies have resulted into viable offsprings. Then nullipara is someone who has never delivered before. Let's continue with the obstetric history. Let's look at terminologies. We have already talked about gravida. So this one refers to the current number of pregnancies. So, like I told you, when the person is pregnant for the fourth time, we consider it as gravida 4. Why? Because he is pregnant for the fourth time. Then T refers to term pregnancy. So term pregnancy refers to the number of pregnancies ending, which is greater than 37 weeks gestation. That is at term. So once the pregnancy reaches 37 weeks and above, that is termed as term pregnancy. Then preterm birth. The term preterm birth refers to the number of the number of preterm pregnancies which ends with less than 20 weeks or viability, but before completion of 37 weeks, in the middle of 20 to 37 weeks. Now, what happens is the pregnancy can surpass 20 weeks but cannot reach 37 weeks, and it is delivered. So in most cases such births happen, and the product cannot actually sustain life, cannot stay on its own. That's why it is termed as preterm. Others can survive, but others sometimes can die. Then A stands for the abortions, which refers to the number of pregnancies ending before 20 weeks of viability. Then the L stands for living children, number of children currently living. So those are the terminologies that you will be seeing more often when you're doing the obstetric history. Then physical examination. When we talk about physical examination, we are looking at the health worker examining the whole body of the pregnant woman. So here we begin by asking the woman to empty her bladder to make sure that we can collect urine that we shall use for specimen or for testing. Then vital signs, we take the vital signs and we watch out for abnormalities. So in this case, we look at the temperature and the BP, and these, if they are high, also when the BP is high, it is suggestive of pre-gestational hypertension, because she is coming to the hospital for the first time. The pregnancy is still within the first 3 months. So if she tests and her blood pressure is high, that means that she had this high blood pressure even before she conceived. That is why we say pre-gestational hypertension. Then we do head to toe assessment. So in this head to toe assessment, we look at the head and the neck, we look at the chest. Then here in the chest, we can anticipate a high heart rate by counting 10 to 15 breath per minute. 10 to 15 this should be 10 to 15 beats per minute, and this is in most cases secondary to increase the cardiac output and the blood volume. Then we expect increase in the respiratory rate to accommodate increase in tidal volume. So now, just to explain this into details, when we are looking at the chest, there are these two things that we are going to look at. First, we are going to look at the respiratory rate. And at the respiratory rate, we are counting to see how the mother is breathing, and we take the breath per minute. So in most cases, the breath per minute for someone who is pregnant is increased. So when when someone is pregnant, there is that increase. Why? Because the lungs are trying to capture more oxygen to make sure that there is enough oxygen in the body. Why? Because of the increased need in the body of the mother. Then the heartbeat in most cases can increase with around 10 to 15 beats per minute, and this is because of the increased output of the blood by the heart, since there is increased demand because of the needs of both the mother and the fetus. So we are still continuing with the physical examination. Then we look for the stria gravidarum. In our previous lecture, we looked at the images of stria gravidarum, and we are now conversant with that. That refers to stretch marks in the layman's language. So at this stage, they may be visible in women with large breasts. So for women who have large breasts, in most cases, the stretch marks or the stria gravidarum can be visible around the breast area, because by this time the breasts have started enlarging. Then enlargement of Montgomery glands. Then this in most cases lead to yellowish secretion that precedes mature breast milk, typically in the third trimester. So the Montgomery glands also enlarge, and these are very, very important for the secretion of milk. So as they prepare to do that function, then they enlarge to make sure that they fulfill that function. So abdomen, including fundal height, if appropriate, is also checked for. So at the belly button, we estimate that the pregnancy should be at around 20 weeks of pregnancy. Then we also check for the extremities. So the extremities, we are looking for things like edema in early pregnancy. We need to rule this out, so that when the mother, as the mother is continuing to progress with her pregnancy, we are aware. If the mother has edema in the early pregnancy, that is suggestive of her likely ending up with hypertension during the third trimester. So we need to watch out for that. Then ask women if she has uh, calf pain. So the calf is the back of the leg. So if the mother feels pain around the back of the leg, more so behind the knee, this in most cases can be suggestive of deep venous thrombosis. So high levels of estrogen places women at higher risk for deep venous thrombosis, or what we can call DVT. Then we go for pelvic examination. Examination of examination of the pelvis externally. So here it requires the mother to be in lithotomy position. The genitalia should be free from lesions, discharge, hematoma, varicosities, and inflammation upon inspection. So when the mother lies on the bed in the lithotomy position, then you inspect the genitalia. You should not observe lesions, discharges, hematoma, varicosities, and any inflammation. Once this appears, that means that there's a problem and you need to act immediately. Then internal genitalia, this one can be done via speculum. So this is why when taking the history, you have to be very, very comprehensive, because if the mother has mentioned something to do with the discharge, then this is the time that you can go in and do the internal genitalia, because because of the discomfort that mothers get. In most cases, it may not be a must that every mother has to be examined for this. So we use the speculum and we check for Goodwell sign, Hager sign, and the Chadwick sign. So these signs, we discussed about them. They include the bluishness of the cervix. They include ballotment and that feeling of increased temperatures within the vagina. So all these ones are checked for. Then your uterus typically is pear-shaped and mobile with a smooth surface. Cultures for gonorrhea and chlamydia can be taken by now during this time of speculum examination for further screening. Then you can do the bimanual examination. This involves the ovaries. This involves examining to check for the ovaries, whether they are palpable and whether they are tender. So the bimanual will involve insertion of 2 fingers through the vagina to then one hand of the examiner is put on the surface of the abdomen. So as she palpates from inside, she also feels from outside to see whether the mother feels pain on that side of the ovaries or not. So ovaries should be small and non-tender without mass. So if there's any tenderness that is felt, then the mother is likely having a complication. Check for the pelvic shape. Gynecoid, is it gynecoid shape? Is it android? Is it anthropoid? Is it platypeloid? So the gynecoid shape pelvis is the one that is typically the female pelvis, and this one has no problem in giving birth. But if the mother is having android or anthropoid platypeloid, then she may have some complications when giving birth. So, pelvic measurements. Now, the pelvic measurements include the diagonal conjugate. The diagonal conjugate is the distance between the anterior surface of the sacral prominence and the anterior surface of the inferior margin of the symphysis pubis. And this is most useful in estimating pelvic size. So as we continue, we also have the true obstetric conjugate. So the true obstetric conjugate, this is the measurement from anterior surface of the sacral prominence to the posterior surface of the inferior margin of the symphysis pubis. Then we have the istiotuberosity, which is the transverse diameter of the pelvic outlet. Then we have the psychosocial and cultural assessment. So as far as the measurements are concerned, the diameters, you should have detailed information on this when you looked at anatomy too. So let us have psychological response. Psychosocial and cultural assessment. So under this we have the psychological response. In this case, we interact with the mother and we see how is the mother responding to this pregnancy. How is she accepting the pregnancy? Does she feel comfortable with this pregnancy? And many other things. Then attitudes towards the pregnancy. Was it a planned pregnancy or was it something that happened accidentally to the mother? Then attitude of significant other and family members. Does she feel blamed? Does she feel like she is doing something wrong keeping this pregnancy, or is she free with it? Are the other family members in support of her carrying the pregnancy, and many other things. Then availability of resources. And now that she is pregnant, are there enough resources that will cater for her throughout the pregnancy until birth and until the baby grows up? Then support systems. Who is there to support her? Are there nearby facilities in case labor starts suddenly? Is there anyone who is going to take her to the health facility? So all this we check for them during the first antenatal visit. Then we also check the financial sources. Is she the one supporting herself? Is the husband there to support, or is any of the family members there to support her? Living conditions. Is she living in good condition, or is she living in a how far did she reach as far as studies are concerned? Did she study that much to the extent that she can be able to provide to herself and to cater for herself, or her education level is low? So because as you are going to prepare health education topics, you should dwell on this to prepare yourself in terms of which language you're going to use to explain to this mother. Does she understand English, or she would prefer you using the local language, and many other things. So it is very, very important to establish this. Then also you have to establish the previous experiences, whether she was pregnant before, or this is the first pregnancy, and if she was pregnant before, how did it go? Did she have good experiences, or she is still in dilemma? Some mothers have passed through some harsh situations. Take examples, losing their babies or losing their pregnancies. So they may be extra careful, or they may have lost hope that even this one I'm carrying, I may not be able to produce or carry until term. Then knowledge level, pregnancy, childbirth, infant care. So does she have knowledge on all this? For instance, prenatal classes. Did she attend any prenatal class? And many other things. Then cultural influences. What are the beliefs and the practices in her society? Is there any communication challenges? Someone who does not use the English, the language that you are using currently, maybe English. Do you require a translator, or do you understand the local language that she speaks, so that you can be able to speak to her in the local language? Then changes in sexual practices. Sometimes the mother can have more desire for sexual or intimacy, and the others may have less desire. So it depends on her desires, and you need to give her counseling based on that. Now, other cultures preserve or prevent the mother from having intercourse. As long as she has conceived, she is not supposed to have intercourse until she produces. Other cultures encourage that she can have intimacy with the husband until she produces. So as when you are talking to the mother, it's very important for you to establish this, so that you don't go against the culture. So you provide something that is culture sensitive, so that you maintain a good relationship with the mother. Laboratory tests. The tests that we carry out during this visit: we do urinalysis, complete blood count, blood typing, rhesus factor, rubella titer, hepatitis B, surface antigen, HIV, syphilis, which can be done through syphilis can be done through VDRL and RPR testing. So any of this can work. Then cervical smears, for pap smear, then ultrasound to check the size and the age of the baby. So these are supposed to be all done during pregnancy, but unfortunately in our country some of these are not available, but we always go with those that are available, mainly the urinalysis, the blood typing, then the HIV and the rhesus factor, then the complete blood count, and sometimes they don't do the complete blood count, but um, they do the hemoglobin, which is very, very important. So let's look at the risk profile. So the goal of preconception care is to identify any areas such as health problems, lifestyle habits, or social concerns that may unfavorably affect pregnancy. So if the mother has the attended preconception care, then she will not have much problem during pregnancy. So a thorough history and physical examination are performed on the initial prenatal visit, like we have described above. We encourage folic acid 400 to 800 micrograms per day, depending on risk profile, as well as proper diet and exercise. So this, we don't have bargain on it anyway, because we know that the folic acid is very important in the prevention of spinal abnormalities. So we encourage that the mother takes it. Then prevents neural tube defects. This I have already talked about it. And elevated levels of maternal serum AFP or amniotic fluid AFP were firstly linked to the occurrence of fetal neural tube defects. So in case of the detection of AFP in the amniotic fluid or in the maternal serum, it can be a question to answer. Why? Because this is likely signifying fetal neural defect. So in case this is as examined and detected in the serum that of the mother or in the amniotic fluid, there is need for the mother to go for further screening to rule out this complication. So follow-up visits, visit schedule. So the mother is supposed to go for a checkup every 4 weeks until she's 28 weeks. So when she reaches 28 weeks, she can go every 2 weeks from 29 to 36 weeks if she's highly at risk. Then from there, she can go every week until she gives birth. That is if she's highly at risk. Assessments. We assess for the weight and the BP. Then we compare to the baseline. Remember I talked about the baseline. Then we also do urine testing for protein, glucose, ketones, and nitrites. Then we check the fundal height every time the mother comes for a visit. These are very important. Now, quickening stroke fetal movement is also observed, usually 15 to 18 weeks if it is the second pregnancy. So if it's the first pregnancy, quickening is expected to be felt 18 to 20 weeks. So this we ask the mother when she comes within those weeks, and we find out whether she has started feeling the baby playing. So it is dependent on whether this is her first pregnancy or the second pregnancy. Then fetal heart rate. Normal heart rate for fetus is between 110 to 120 beats per minute. This is within the normal. If it is lower, then there's a problem, and if it is higher than that, it is also a problem. So we teach about the danger signs. Dependent edema is okay. But if it is persistent, then it's not okay. So when do we talk about the dependent edema? The dependent edema is kind of edema, like for instance, if the mother has stood for long, then she develops edema. But if she lies down, then it wears off. That is normal. If she sits for long, then she develops edema. When she lies down, it wears off. That is also normal. But if the edema is persistent throughout, then there is a question. So when teaching about danger signs of pregnancy during the first trimester, danger signs include spotting or bleeding. This can indicate miscarriage. So if the mother is having this, and if there is painful urination, it also indicates infection. Severe persistent vomiting, this indicates hyperemesis gravidarum. Then if there is a fever of greater than 37.7 degrees Celsius, this also indicates infection, likely she has malaria or any other thing. And lower abdominal pain with dizziness, and accompanied by shoulder pain. This can be indicative of ruptured ectopic pregnancy. Then in the second trimester, we have things like irregular uterine contractions. These can indicate preterm labor. Then pain in the calf, often increased with the foot flexion, that indicates a blood clot in deep vein. Then sudden gush or leakage of fluid from vagina. This can indicate premature rupture of membranes. And the absence of fetal movement for more than 12 hours. This indicates possible fetal distress or demence, meaning likely the fetus has died. So all these, if observed within the first trimester, those make sure that you rush the mother for help, because she is in danger and also the fetus is also in danger. Then also in the second trimester, if you observe those, please run for help. It is not safe. Then in the third trimester, there is sudden weight gain, periorbital or facial edema, severe upper abdominal pain or headache with visual changes, gestational hypertension and or preeclampsia, and a decrease in fetal daily movement for more than 24 hours. This means that there is a possible demise of the fetus. Now, any of the previous warning signs and symptoms can also be present in the last trimester. So the previous ones that we have discussed about, that we said can be in the first or the second trimester, can also still be present in the third trimester. And once observed, help should be sought for as soon as possible. So let us look at assessment of fetal well-being. So assessment of fetal well-being, this will include ultrasonography, Doppler flow studies, alpha fetoprotein analysis, then marker screening tests, mucotranslucency screening, which is done using the ultrasound. Then for early detection and the diagnosis of some fetal chromosomal and the structural abnormalities. So these are the assessments that can be done mainly to rule out any complications with the fetus. So in our country currently, I think some of them are not there, but I am very sure we have the ultrasound, we have ultrasonography, likely. Then we have Doppler is also there. Then we have other assessments that can be done, such as amniocentesis. That is, a sample can be taken from the amniotic fluid for analysis. So this can be done to study the chromosomal abnormalities and the hereditary metabolic defects before birth. This can reveal whether there are other defects in the baby before birth. So this can be used to confirm fetal abnormalities when other tests detect possible problem. So what is the nursing management? The nursing management is, we have to explain the procedure and the risk to the mother, then encourage the mother to empty bladder before puncture, then afterwards position in comfortable position so that the sample can be able to be taken from the mother, the amniotic fluid. Then administer RHOGAM if the patient is rhesus negative, to make sure that incompatibility is not created. Otherwise, it can lead to losing of the fetus. Then assess vitals and fetal vitals every 15 minutes. Observe puncture site for bleeding or drainage. Instruct women to rest at home and to report any abnormalities. When results come back, refer to genetic counselors so that the women are counseled in case of any abnormality and how it can be handled. Let us look at chorionic villus sampling. Used for chromosomal disorders. We don't encourage the mother to empty the bladder. Then we also explain potential complications to her, which include vaginal bleeding, cramping, abortion, lymph abnormalities, um, rupture of the membranes. Then explain that procedure lasts 15 minutes. Ultrasound is done to locate embryo and baseline vitals are taken before the procedure is done. So assist women to comfortable position, assist women to comfortable position and clean excess lubricant. Urge her to not engage in strenuous activity for the next 48 hours. Then we also uh, administer the ROGAM if the mother is rhesus negative to prevent the creation of incompatibility. Then we have percutaneous umbilical blood sampling, PUBS. Then we have, okay, this is a non-stress test. So normal fetus heart rate accelerates in response to movement. Nursing management, we encourage the women to empty the bladder, then also obtain baseline fetal monitor strip over 15 to 30 minutes. Then afterwards, help women off table and provide with the fluids. Then we have the contraction stress test. This one is used with the non-stress test, and the objective is to reduce stillbirth or and detect hypoxia to allow delivery damage resulting from fetal asphyxia or deprivation of oxygen. Then another test is the biophysical profile. So these are the tests that can be done to assess the well-being of the fetus. Thank you so much. I went slow in this lecture to make sure that you can be able to capture all this because it's very, very important as far as a health worker is concerned, more so for the nurses and the midwives. Thank you for being part of this lecture today. May God bless you. Hello?